We move on now to our next presentation while we are waiting for Dr. Gaurav Luthra to join us. Dr. Tushya Prakash will be talking to us about how you deal with a posterior polar cataract which has an open capsule.
I would like to thank Dr. Vishali for giving me this opportunity. So, I would be talking on successfully navigating a posterior polar cataract with an open posterior capsule. So, I'll be showcasing you few posterior polar cataract cases. So, this is the first case where, with the posterior polar cataract with the nuclear sclerosis of grade 3. So, we have been doing preoperative OCTs in all our posterior polar cataracts to diagnose any kind of these pre-existing tears preoperatively. Thanks to Dr. Pujari, he has published a very good paper on that. So what I usually do is, so this case already had a pre-existing PCR which was confirmed with the preoperative OCT with the conical morphology. So what I usually do is I keep my, there are some prerequisites involved before the surgery. So first thing, important thing is to have calibrated incisions, because you can't afford to have leakages during the surgery. So calibration of side port as well as main port is important. Active fluidics is another important thing. I don't have any financial disclosure. And then slow motion phacoemulsification approach as shown by Dr. Robert Osher and low IOP by Dr. Abhay Vasavra. So our aim here is to have an equal or minimal pressure difference between the interior and posterior segment so that there is no pushing back of the nucleus to the posterior segment. So another thing which is very important is use of oval rhexis, because this gives you an advantage of both large as well as small arm of rhexis. Large arm of rhexis helps you and there's no rise of intraocular pressure. You can do a safe end-to-end sculpting. There is easy division, easy sub-incisional cortex removal and a smooth IOL entry. With the small arm of rhexis gives you an option of optic capture, nuclear piece retention in the bag, and also helps in tamponading the vitreous. So my machine settings would be that I usually use a low IOP of 20 to 24 physiological IOP with a low vacuum and an aspiration flow rate. So in this case, the cataract was on a harder side. So for quadrant, I usually increase the vacuum, and as Dr. Vasavra says, you can also keep the aspiration flow rate low. So starting with the case, the first important thing is have calibrated incisions, so to have minimal leakage, good chamber stability, and oval rhexis, as I already told you about the advantages, it gives you an advantage of both small and large arm of rhexis, and you can also, it gives you an option of doing an optic capture later on. So my aim here is to do stop and chop technique, slow sculpting, slow division of the nucleus, and slow motion phacoemulsification, because you can see here I'm slowly dividing the nucleus hemispheres. Cross chopping is done where the nuclear piece adjacent to the 6 o'clock is being aspirated as shown by Dr. Ron Yaw. And now the remaining hemisphere is slowly divided so that it is separated from the other hemisphere. With the back flip, it is brought into the interior chamber, and you can see my IOP settings. They are all low phaco parameters, low IOP, low aspiration flow rate. The aim here is to have a minimal pressure difference between the interior and the posterior segment so that these nuclear pieces are not pushed back. There is no undue deepening of interior chamber, no posterior bulging of the posterior open capsular defect. The remaining hemisphere is brought into the interior chamber, and it is slowly aspirated. I would like you to focus on those three nuclear small pieces which are lying over the hyaloid phase. So minimal turbulence and low pressure fluidics prevents any disruption of the hyaloid phase. So what I'm trying to do here is I'm trying to use the hyaloid phase to my advantage. So that is acting as a shield to these small nuclear fragments. You can see those two small nuclear fragments which are just lying over the hyaloid phase, and it is acting as a shield to these nuclear fragments from going back. So low IOP phacoemulsification maintaining the equilibrium, the interior chamber pressure and the posterior chamber pressure. So there is no disruption of the, always remember to inject viscoelastic before taking out the probe to maintain the chamber sending. Remember not to overinflate the chamber with viscoelastic. And with visco expression, you can see that one of the small nuclear piece is being taken out. Remember not to overinflate it have to be done meticulously. Dry aspiration by Gill's technique has been followed to prevent any vitreous hydration, and you can see here that with the dry aspiration the remaining cortical matter is taken out. And with now my plan here is to inject an IOL into the sulcus, as I already had an oval rexis, so I'm going to use that to my advantage. I'm going to do an optic capture, and you can see here this remaining small nuclear fragment which was lying over the hyaloid membrane, and now the lens is optic captured and triamcinolone acetate confirmed absence of vitreous, and the case was completed. So with this animation, I would like to tell you is that when you have low chamber settings and low IOP, these nuclear pieces, they just bounce back and hyaloid phase acts as a shield to it. So this is another case of posterior polar cataract where with a young 32-year-old male, overly soft posterior polar cataract, preoperative OCT shows moth-eaten morphology, which confirms a pre-existing defect. So now I'm gonna start my case. Calibrated incisions is very important at the start of the case, and then followed by an oval rexis. So this has both the advantages of small and large arm of rexis. So I can use this to my advantage later on by doing an optic capture if needed. And now as ma'am had also shown initially, that these overly soft cataracts, so we don't do hydrodissections in any of these posterior polar cataracts with pre-existing defects. So I'm gonna do layer by layer hydrodelineation. So where the BSS is injected at different levels and different planes. So aim here is to have these layers, because to have a good thick epinuclear sheet, the outer nuclear layer is used as a scaffold, is used as a shield to the open posterior capsular defect, and the inner nuclear layers are phacoaspirated. They are phacoaspirated slowly, keeping in mind not to do any rotation maneuvers. So the inner nuclear layers are aspirated. The chopper helps in doing a mechanical delineation of the nuclear layers. So with the mechanical separation of these nuclear layers and phacoaspiration, the inner nuclear layers are taken out. So what I'm going to do here is, as Bob Usher has also mentioned, I'm trying to take out the epinucleus on the opposite side. So this gives you an escape route to the BSS, which just goes and immobilizes the outer nuclear layer without providing any stress on the posterior capsule. So with the escape route, and always remember to inject viscoelastic before taking out the probe. So bimanual IA could have been done. So what I do is I do a high sleeve retraction of coaxial IA, so that it gives you a different level of irrigation and aspiration, which simulates a bimanual IA. So now the epinucleus is taken out from all the ends. So once it is taken out from all the ends and it is aspirated softly, and always remember to use low phacoparameters, low IOP, because you don't want your posterior capsular defect to extend. And once it is dislodged from all the ends, it is aspirated quickly. So you can see here, there's always remember to inject viscoelastic, not to overinflate it. So you can see the posterior capsular defect. I'm trying to regularize the posterior capsular rexus. So I usually go in through the side port just to maintain a good chamber stability rather than going from the main port. So now it is rounded off. And from the other side also, I was trying to round off the rexus. So to have a, so now triamcinolone acetate confirmed the absence of vitreous, and the IOL is injected into the sulcus with an optic capture, and the case was completed. So this last case, a very short video, just wanted to tell you about this case. The patient was diagnosed with a preoperative PPC with pre-existing defect, confirmed by OCT. So, and patient was a high demanding patient with high amount of astigmatism, wanted a toric IOL. So as a routine case, I continued the phacoemulsification, low phaco parameters, the nuclear emulsification was completed. You can see a typical posterior capsular defect. Remember to inject viscoelastic before taking out the probe, and IA was done. And now again, always remember to inject viscoelastic before taking out. So what I'm gonna do is I'm gonna regularize my rexes by trying to rounding it off. So once this is done, what I'll do here is now I'm gonna inject a toric IOL. So I'm gonna do it in such a way that I would place it over the iris. Make sure that your chamber is adequately deepened with the viscoelastic. Align it at the axis. So once your chamber is adequately deepened, you slowly flex your haptic into the capsular fornix. So it has been lined before by keeping it on the iris, and with the other haptic going in, you can just place it in the back. So this is one way, and other way is what Dr. Vasavra says, to do a reverse optic capture also. That also you can do. So thank you so much. Yes, ma'am. Yeah, so I've tried it in few. That's why I go it through the side port. Make sure that like it is at the chamber is not overly inflated adequately. Yeah, yeah. At times it is through and through, so you can't do it in that. Like, but if you have a smaller one, you can try.
I think, like you rightly said, ma'am, a lot of these are very fragile, floppy kind of
Yeah.
capsules. So you can't always convert it, but those were very good tips, Tushya. I think the most important thing, like you said, is pre-operatively anticipating and also counseling the patient that things may not go as you were planning. So if you have a retinal surgeon available in your hospital, it is a good idea to have them on call that if I need, please come up and scrub with me. If not, you need to tell the patient in both situations that we might have to go behind and do a vitrectomy, and which is because you have this defect. And these imaging I also find very important because you can show the patient pre-operatively that this is what you have as compared to what a standard cataract would look like. So in these days it's also very important to have these attached to your case reports so that you have a record of what you were doing. And I think the other surgical points were very well taken. Lower your parameters, slow down your technique, always inject dispersive viscoelastic before you withdraw, and having a good rexis size so that in case you have to do a sulcus implantation with or without capture, you shouldn't have too large a rexis in these cases. Any other tips, Rohan or Dr. Vanna?
So, emulsification in the bag versus emulsification in the AC. Like in softer cataracts, it's fine to do that. But like when it comes to slightly harder cataracts, how do you decide that? Like in posterior polar cataracts.
In posterior polar cataracts, I try to do, first of all, we don't have to rotate. So if it is a harder cataract, try to do cross chop, okay, or as I showed you one.
No, emulsification, the quadrant removal.
So in quadrant removal, I always take it in the safe zone. I always try to do it supracapsularly if there is a pre-existing defect.
So I think, Rohan, that's also a good point, but like many stalwarts have taught us, if you reduce your parameters and if you're slow, most of the times you can manage. In bringing it supracapsular, sometimes you may be, if you don't know there's a vitreous, you might be pulling more vitreous. Second, you are working close to the endothelium, so even the fluidics and everything, you don't want to add a component of corneal endothelium. So as long as you can, maybe last fragment, yes, but as long as you can, I would suggest just go slow with your bottle height, flow rate, and adequate vacuum, and most of it will be done in the bag, or at least at the iris plane.
Yeah, iris plane.
Yes, sir.
Yeah.
Yes, sir.
Yes, sir, yes.
everything needs more and more proof of why it is happening. See, posterior polar, if I'm right, it's a remnant of the hyaloid system which is altered. So I think you said some of them behave differently, some of them. So it is very important to study the proteomics of those caps, because you took it out very well, and preserve it, and say around 20-25 of these capsules, if you're able to provide along with the lens, and compare it with the non-polar ones, you might unlock a completely new pathways. See, the question is, what happens if you unlock a new pathway? There is a potential tomorrow for a drug delivery of system, something. I mean, we never know what you will unlock it. So my suggestion is that, because when you are taking out those rexes of the posterior, it is a phenomenal use to science. And there are people who have worked on anterior capsules, different types of anti-capsules, the capsule which has fibrotic. And there's a work done here which shows that the fibrotic capsules can be prevented by using something like resveratrol, because this has a tremendous role in reducing the fibrosis. We never know what you get. Just a suggestion from a non-cataract surgeon is that now you all mature to a level of phenomenal surgical skills. Now I think you should put your efforts into unlocking the pathways of these rare types of cataracts, and how you can look at what proteomics are involved in it. And if you visit one of your labs, and whether in Ahmedabad or Amritsar, I think they'll be able to do it. It's not so complicated.
I think that's a great suggestion, and a few years back we have done some studies on the plaque capsules, but I think we really haven't done a head-to-head on normal versus polar, so yeah, it's time to work together.
Great comments, and thank you for suggesting these paths. We attempted a few paths like that, but we are still lost. But I just want to congratulate you, Tushya. Wonderful, wonderful skill and exhibition. I just want to emphasize one point. There are many points, but if I have to single out, in addition to what you said, is the delineation, and you showed it very well. Creating a cushion, protecting the weak, fragile capsule during the removal of the nucleus is very important. And there are many ways of doing it, but you need to do delineation. Doing it in a conventional way, sometimes the fluid goes inadvertently into the wrong subcapsular plane, and then it can hydrorupture it.
Yes,
so I think doing a technique called inside-out delineation or something, create a space in the middle and then delineate to avoid that inadvertent thing would be a good idea. You can do much controlled way in the flex technique, but that kind of creating a cushion is very useful, particularly if there is already open capsules. But you showed it so well.
Thank you, sir. Thank you.
Just one question, Dr. Om Prakash. You showed the dry aspiration of the cortex. What is the cannula through which it was coming out so easily? And what was the viscoelastic at that time?
So ma'am, I was using a viscodispersive HPMC, and it is a 25 gauge cannula. This technique has been shown by Dr. Gill. So it is, you can always ma'am read about it. So it is irrigation, aspiration, fixing, teasing and stripping of the cortex with